Good afternoon. The patient is an 83-year-old, well-appearing white male who presents to the clinic with a significant past medical history of 2 heart attacks suffered due to blockage of his left anterior descending coronary artery and contraindicated treatment with aspirin and clopidogrel, who presents to the clinic for a routine cardiac follow-up. Patient suffered a non-ST elevated myocardial infarction on November 29, 2011 due to 2 blockages of his left anterior descending coronary artery. After being stented, the patient was placed on a thrombolytic and antiplatelet therapy regimen with close consultation from a GI specialist due to the patient's bleeding disorder known as hereditary hemorrhagic telangiectasia. His hereditary hemorrhagic telangiectasia complicated his treatment, and he suffered a gastrointestinal bleed, which led to the patient being transferred to the ICU for immediate transfusion of 6 units of packed red blood cells and removal from his thrombolytic and antiplatelet therapy. The patient subsequently progressed to having an ST elevated myocardial infarction. 10 days later, he remained hospitalized for 6 weeks until January 4, 2012, and his current symptoms include nosebleeds, continued left leg swelling, and sleep apnea. He has progressed to walking around the block with a physical therapist and his son, and he also does not suffer from any angina nor shortness of breath. His past medical history is significant for his bleeding disorder, HHT, sleep apnea. His past surgical history includes 2 lung operations, a lumbar disc surgery, rectal operation, and a vasectomy. His family history is significant for his father having a stroke in 1976. One of his brothers passed from cancer, and another passed from the same bleeding disorder that the patient suffers from, HHT. He is a 20-year military veteran, 3 spent with the Navy and 17 with the Army or Air Force as an enlisted man. His wife died in 2000. However, he is taken care of by his son. He is on a well-controlled, low-sodium diet and exercises only rarely with his physical therapist and with his son. He quit smoking approximately 60 years ago and quit drinking alcohol approximately 5 years ago. His wife died from cancer due to smoking her entire life. Medications include doxysate sodium, Senna, and polyethylene glycol for laxatives due to his rectal operation, as well as ferrous sulfate to help with his hereditary hemorrhagic telangiectasia. He's on albuterol, Advair, tiotropium, and montelukast for COPD-like symptoms. He's also on lisinopril, atorvastatin, furosemide, phenolazine, nitroglycerin, esomeprazole, and metoprolol for his congestive heart failure symptoms. He has no known allergies to medication. However, thrombolytics and antiplatelets are both contraindicated in this patient due to his bleeding disorder. On physical examination, his blood pressure was 130/70, respiratory rate was 14, heart rate was 70, and his temperature was 98.6. He maintains a constant weight of 187 pounds. On inspection, there was no displacement or visible pulsations of his chest wall. He had a normal bilateral rise and fall. However, he did have the skin and oral telangiectasias and a swollen left lower extremity. On palpation, his carotid arteries were palpated. Chest wall was palpated at the 4 valvular heart areas, and no thrills or rubs were noted. He did, however, have a +2 pitting edema of his leg. No bruits were heard over the carotid arteries, and no murmurs, thrills, or rubs were noted over the 4 valves of the heart. On imaging, ultrasound showed an apical akinesis following his 2 heart attacks of the distal anterior wall of his left ventricle, and an ejection fraction of approximately 30 to 35%. The patient is an 83-year-old, well-appearing white male with a significant past medical history of 2 myocardial infarctions and HHT complicating his therapy. Summary: he's taking medications for his HHT, his COPD, and his congestive heart failure symptoms. He appears well, and his apical akinesis and low ejection fraction do not appear to be affecting his daily life. I would continue this patient's current medication treatment and recommend follow-up visits every other month.